Imagine trying to cut through that jungle of scientific papers, looking for that one little nugget of insight that's actually tailored for you.
Yeah, it's a lot.
Because, let's be honest, the sheer volume of information out there, especially in something as complex as medical research, it can feel, well, completely overwhelming.
Definitely.
And that's really why we're here doing the deep dive. Our whole mission is just to filter out the noise, pull out what's truly important, and maybe uncover those surprising facts that make you kind of lean in.
Make you go, huh, okay. And today we're taking a deep dive into a really critical area, a clinical trial looking at new treatment options for HER2 positive advanced breast cancer.
Right.
And this is a particularly tough spot for patients and for clinicians too. You're often dealing with cases that have been heavily pretreated. Many standard options already tried.
So doctors are really searching for effective new paths.
Exactly.
And our main source material for this deep dive is the GYM-12 Tiger trial. It's a randomized phase 2 study just published in The Oncologist, July 2025.
And it offers, I think, a really compelling look at balancing treatment effectiveness with, well, patient well-being, quality of life.
That's the core question, isn't it? Could a chemotherapy-free approach actually give similar benefits to traditional chemo for these patients, especially thinking about how they feel day to day? So what does this all mean for you if you or maybe someone you know is facing these kinds of really difficult decisions?
Okay, so maybe let's set the stage a bit. HER2 positive advanced breast cancer.
Yeah.
What is it? Why is it such a focus for research?
Good idea.
So HER2 positive means the cancer cells have too much of a protein called HER2 on their surface. Human epidermal growth factor receptor 2 is basically like a growth switch stuck in the on position.
Driving aggressive growth.
Right. And for patients who are in later lines of treatment, meaning they've already had several therapies, a standard approach often involves combining a targeted drug, trastuzumab, with chemotherapy.
And like you said, the treatment landscape is just constantly shifting. Clinicians have this really challenging job trying to figure out the best sequence of therapies.
Especially after multiple prior treatments.
Yeah, which is exactly why alternative options are so vital. For when chemo isn't suitable or maybe just not well tolerated, it's about finding paths forward for everybody.
And that brings us right to the GYM-12 TIFER study design. So the main goal was to look at the efficacy, the side effects toxicity, and really importantly, the quality of life for two different strategies.
Okay.
And this was specifically in patients who had already had at least 2 prior anti-HER2 treatments. So quite heavily pretreated.
So how did they set up these two strategies? What were the arms?
Right. So arm A was the experimental one, the chemo-free arm. Patients got 2 targeted therapies together.
Yeah.
Trastuzumab, which you mentioned, that antibody hitting HER2, and lapatinib. That's a small molecule drug that also blocks the HER2 pathway, just in a slightly different way.
Okay, 2 HER2 blockers, no chemo.
Exactly. And an important detail, if patients also had hormone receptor positive disease, meaning hormones like estrogen also fuel their cancer, they got endocrine therapy too.
Right, blocking that pathway as well. What about dosages?
For arm A, it was oral lapatinib, 1,000 milligrams daily, plus trastuzumab given intravenously, standard dosing, 8 milligram kilog load, then 6 milligram every 3 weeks. They also allowed a subcutaneous version under the skin later on. More convenient sometimes.
Okay, that's arm A chemo-free. What was the comparison arm B?
Arm B was the control group. So patients there got trastuzumab, same HER2 antibody, but with chemotherapy chosen by their physician.
Ah, so trastuzumab plus chemo.
Yes. And the study notes that vinorelbine, which is a pretty common chemo agent, was the one used most often in this arm. About 60% of the patients in arm B got that specific chemo.
60%. Okay. So once they had these 2 arms set up, how did they actually measure success? What were they looking for?
The main target, the primary endpoint, was something called the clinical benefit rate.
CBR.
CBR. Okay, what does that mean exactly?
It's a composite measure. It counts patients who had a confirmed complete response, meaning the cancer disappeared.
Or a partial response, so significant tumor shrinkage. Or stable disease, meaning the tumor didn't grow, but, and this is key, for at least 24 weeks, 6 months.
Okay, so response or stability for a good chunk of time.
Exactly. Then they also looked at secondary endpoints, things like overall survival, OS, how long patients lived, progression-free survival, PFS, how long until the cancer worsened, overall response rate, ORR, just the percentage with complete or partial response, and crucially, quality of life, QOL.
And how do they measure QL? That seems
They
subjective.
used a standardized, validated questionnaire called the FACTB. It's specifically designed for breast cancer patients and captures different aspects of well-being.
Got it. Now, before we jump into the results, which sound like they could be really interesting, we need context, right? Any limitations or things we should keep in mind about this study?
Absolutely critical, yes. So this was an open-label phase 2 trial. Open label means both patients and doctors knew which treatment was being given. It involved 59 patients across 16 centers in Italy.
59 patients. That doesn't sound like a huge number.
It's not. And that's the key limitation. The study actually closed early, and they enrolled far fewer patients than their original target, which was 77 per arm.
Oh, wow. So they aimed for over 150 and got 59 total.
Precisely. And because of that small sample size, all the results have to be considered exploratory.
Exploratory, meaning?
Meaning the study wasn't really powered, didn't have enough statistical strength to definitively prove if one treatment was better than the other, or even to make firm comparisons. It generates hypotheses, suggests trends, but doesn't give final answers.
Okay, that's really important context. Exploratory findings.
And linked to that, the study didn't actually meet its primary endpoint goal. They were aiming for a CBR of 35% in either arm, and they didn't hit that number in Arm A or Arm B.
Right. And wasn't there something about the patient characteristics too? Hormone receptors?
Yes, good point. About 70% of the patients in the trial had HR-positive disease, hormone receptor positive, along with being HER2 positive.
And that matters because
HR-positive disease is often associated with maybe less dependence purely on HER2 signaling. It can sometimes mean a reduced response to anti-HER2 therapies alone. So having such a high proportion of HR-positive patients might also have played a role in the overall results and why the CBR target wasn't met.
Okay. So small study, exploratory results, didn't meet the primary goal and a specific patient mix. Got it. With all that in mind, what did they find in terms of efficacy? How did the arms compare?
Well, this is where it starts getting interesting, despite the limitations. When they looked at the efficacy measures, the differences between the chemo-free arm, Arm A, and the chemo arm, Arm B, were not statistically significant.
Not significant. So basically similar outcomes.
Pretty much within the limits of the study's power. For instance, that main endpoint, CBR, it was 20.7% of the chemo-free arm versus 26.7% of the chemo arm. The p-value was 0.76.
Okay, p-value 0.76. Remind us what that means. Higher is less significant.
Yeah.
Exactly. A p-value above 0.05 generally means we can't confidently say the observed difference is real and not just due to chance. 0.76 is very high, so no statistically significant difference there.
And what about things like how long patients went without the cancer progressing, the PFS?
Similar story. Median PFS was 3.6 months in Arm A versus 6.1 months in Arm B. The numbers look a bit different.
Yeah, 6.1 sounds better than 3.6.
It does numerically, but the p-value is 0.08. Still technically not statistically significant by the conventional 0.05 cutoff, though it's closer. Suggests maybe a trend, but not proof within this study.
Okay. And overall survival, how long people lived?
Again, very similar. Median OS was 29.9 months in Arm A versus 31.1 months in Arm B. Almost identical, really. And the p-value is 0.82. Very high.
So despite the numerical differences you might glance at, the statistics say, look, based on this data, we can't claim one was better than the other for efficacy. They perform similarly.
That's the takeaway on efficacy, yes. No clear winner just looking at tumor response or survival in this exploratory analysis. Which then brings us, I think, to the really unexpected part. The quality of life findings.
Yes. This is where, for me, the study gets really interesting. The twist. Despite that similar efficacy, they found a statistically significant difference in quality of life.
Okay.
Favoring which arm?
Favoring the chemotherapy-free arm. Arm A, the trastuzumab plus lapatinib group.
Wow. Okay, tell us about those QOL scores. You mentioned the FECTB questionnaire.
Right. So they looked at the change in the QOL score from when patients started the study. In Arm A, the chemo-free arm, the average score actually increased by 2.4 points.
Increased. So quality of life got better on average.
Exactly. An increase suggests improvement. But in Arm B, the chemotherapy arm, the average score decreased by 6.4 points.
Decreased. So it got worse. That's quite a
Yeah.
difference. Was it statistically significant?
It was. The p-value for that comparison was 0.03. Which is below the 0.05 threshold. So yes, a statistically significant difference favoring the chemo-free arm for quality of life. That's fascinating. Chemo-free arm improved QOL. Chemo arm saw it decline, even though the cancer control was similar. But wait, what about side effects? Adverse events.
Wow.
Usually better QOL means fewer side effects, right?
You'd think so. But here's the paradox. The plot thickens, as they say. Overall, adverse events were actually more common in the chemo-free arm, Arm A.
More common. How much more?
86.2% of patients in Arm A reported some adverse event compared to 66.7% in Arm B.
Okay. And what about severe side effects, grade 3 or 4?
Also higher in Arm A, 24.1% experienced grade 3 or 4 events in the chemo-free arm versus 13.3% in the chemo arm.
Hang on. So Arm A had better quality of life despite having more overall side effects and more severe side effects. How does that work?
It sounds completely counterintuitive, doesn't it?
It really does.
But this is the really crucial nuance. It highlights that quality of life isn't just a simple count of side effects, it's much broader. It captures physical, emotional, social, functional well-being,
Yeah.
the whole picture. So while the chemo-free arm might have had more specific reported AEs, maybe the type of side effects were different or more manageable day to day compared to the systemic impact of chemotherapy.
Ah, the type of side effect matters. What were the common ones in each arm?
In Arm A, the chemo-free arm, the big one was diarrhea, 37.9%. Also fatigue, low platelets, nausea, fever, skin issues, things around 10-25%. Manageable for some, but definitely present.
Okay. And Arm B, the chemo arm.
The most common things there were neutropenia, that's low white blood cells, increasing infection risk at 16.7%, and paresthesia, tingling, or numbness, often in hands and feet at 13.3%.
So maybe things like chronic fatigue or persistent numbness from chemo, even if reported by slightly fewer people overall, had a bigger negative impact on daily living and overall QOL than, say, manageable diarrhea.
That's likely the interpretation, yes. Diarrhea can often be managed with medication, diet changes. Whereas chemo side effects like severe fatigue or nerve damage can be really debilitating and harder to control, significantly impacting what a person can do. It also matters that no severe heart toxicity was seen in either arm, which is always a concern with HER2 therapies.
Right.
So the bottom line here is that fewer reported side effects on a checklist doesn't automatically mean a better patient experience. It's about the impact of those side effects.
That is such a critical distinction, not just the count, but the quality, the lived impact. So wrapping this up, what's the big picture takeaway here, keeping those limitations in mind?
Well, I think the key insight, even from this small exploratory study, is that trastuzumab plus Lapitin, this chemo-free combo, could be a viable option for some patients with heavily pretreated HER2-positive advanced breast cancer.
Particularly valuable for who?
Particularly for patients who maybe can't tolerate chemotherapy or really want to avoid it. It offers an alternative that seems to maintain similar clinical benefit, at least in this context, but with a potential advantage in quality of life.
It really underscores the need to tailor treatment, doesn't it? Looking beyond just the tumor response numbers.
Absolutely. It's about individual patient needs, priorities, and well-being.
And just to remind everyone again, those crucial caveats: exploratory phase 2, small size.
Right. Not definitive. And crucially, the treatment landscape has changed dramatically since 2015 when the study was running. We now have newer, often very effective agents like trastuzumab, deruxtecan, tucatinib.
Which weren't tested here.
Correct. So these results are very specific to the context and time they were studied. But the principle they highlight remains incredibly relevant.
So recapping the core insight from this deep dive into GEM12-TOFR, a chemo-free option showed similar efficacy to a chemo combo in this exploratory setting.
But with a significant advantage for patient quality of life, despite having, paradoxically, more reported side effects overall.
It's such a powerful reminder, isn't it, that treatment isn't just about adding months or years, but about the quality of that time.
Absolutely. Incorporating QOL seriously into clinical decisions is paramount.
So maybe a final thought for you, the listener. As medical science keeps advancing, how do we really weigh these different aspects of success? It's not just extending life, but truly enhancing the patient's lived experience. What stands out to you when you think about these kinds of trade-offs in treatment?